This next session is about centers of excellence and what do we do if we don't have one near us. You are basically on the grounds of a center of excellence right now. I feel like I really lucked out geographically when I found out I had Cushing's because I was right here in Emory's backyard in Pituitary Center of Excellence. So I think my outcome would have been a lot different if I had had to hunt around and try to figure out where my nearest specialist was and, God forbid, fall to the hands of social media to tell me where I should go. So this is my endocrinologist, Dr. Adrian Iacomeșcu, and Dr. Nicholas Tritos will also be discussing the centers of excellence and what to do. And so I forget who starts. Is it you? Yes, Dr. Tritos will start. Thank you.
Thanks so much, Leslie, for the kind invitation. Good afternoon. I'm Nick Tritos from Mass General in Boston. It's so nice to be in Atlanta. It's about 50 degrees warmer than it is in Boston right now, so I'd rather stay a little longer. So many thanks to everybody for joining us here today. So first of all, by a show of hands, how many of you have had any difficulty going to the doctor or the surgeon of your choice or having surgery, not necessarily pituitary, it could be adrenal, at the center of your choice? So a few people. So it's not an unusual situation, I'm afraid. So what I would like to talk about briefly in the next few minutes is, first of all, discuss the concept of the Pituitary Tumor Centers of Excellence as it has been proposed by the Pituitary Society, and then share with you some of the data that are published with regards to the outcomes of the patients in relation to the surgical expertise, and then discuss some of the efforts that are being made by the Pituitary Society about putting forward the concept of the Pituitary Tumor Centers of Excellence into and moving that forward. So what is the proposed definition of the Pituitary Tumor Centers? These are supposed to be multidisciplinary centers designed to provide the best possible care for the patient with pituitary tumors or other related pathologies, including, of course, Cushing's disease. They are also meant to provide patient education, being active in community outreach, act as training centers for residents, other healthcare professionals, advance pituitary science, be recognized by professional organizations, and also be accredited and periodically audited. And currently, of course, there are many centers around the country that excel in surgery, including pituitary surgery, but when it comes to the pituitary, there's no formal accreditation process in place. So the question is, does it matter? Of course, intuitively, we would say yes. When you fly on a plane, you want your pilot to be trained and have ample experience. You want your surgeon to have experience, right? But do we have any information? Do we have any data to make that point, to validate that point? So Harvey Cushing, who of course gave the eponymous, his name to the eponymous condition, indeed noted that mortality improved vastly during his career. Before his time, about 40% of patients who underwent pituitary surgery unfortunately died around the time of the surgery. And even starting early on, the mortality dropped significantly to 13%. When he started doing pituitary surgery. He was a very meticulous surgeon. And then close to the end of his career, about 20 years later, as you can see, it was about 3.9%, still high by today's standards, but of course much better. So, but of course this is just one surgeon. Can we generalize these observations? There's a little bit of data, and I apologize for the small size of this slide. And this is a study that was published in Wales, actually. And what they looked at is the outcomes of their patients with Cushing's disease who had surgery in relation to surgical expertise. Each line, each horizontal row represents a different surgeon. So they had 3 different surgeons. Surgeon A did about 10 pituitary operations per year. Same was true for Surgeon B. And then Surgeon C, the last one, did about 30 pituitary operations per year for a number of years. And he was the only one who was doing pituitary surgery during his tenure at the institution. And what they look at is the remission rates and the hypopituitarism and complication rates. So what you can see that was interesting to me was that for smaller tumors, and as we know, most patients who have pituitary Cushing's have small tumors, 90% have what we call microadenomas, tiny tumors. Indeed, it appears that the last surgeon who had the most experience had 100% remission rates. His patients really did well. They did not do as well when they had larger tumors, those who had the extracellular tumors. These were larger tumors that were harder to remove. But also look at the risk of hypopituitarism. The last surgeon was the one who did best when it came to the complication of pituitary dysfunction as a result of surgery. So his patients really did the best. Again, these are small numbers, not totally convincing, but nevertheless, it is consistent with the notion that surgical experience is associated with better outcomes. More recently, there was a larger study that was published, and this was done actually primarily by neurosurgeons from our institution. They looked at national data, and these were data using insurance claims databases. So the so-called nationwide inpatient sample between 1996 to 2000, and this covers about 20% of pituitary operations in non-federal hospitals in the US. So, and it's supposed to be representative of the entire population. So the aim of the study was to look at how patients did, how likely were to go home as opposed to a rehabilitation facility, what was the mortality risk, what were the complications, hospital charges, in relation to the hospital and surgeon's experience and expertise. So here's what they found. So large number of patients who underwent pituitary surgery, about 5,497, as you can see. On the average, they were 49 years of age, but this was a huge spread from infancy to advanced age. About 50%, 53% were women. And as you can see, Cushing's disease was actually 7% according to the codes. Of course, this is based on insurance coding, so it may not be totally accurate. But it was only a small proportion of these patients had pituitary surgery. Others had acromegaly or other pituitary conditions. So the number of hospitals that were surveyed included 538 hospitals across the country. And you can see immediately that the in-hospital mortality was 0.6%. So this is vastly better than Harvey-Cushing's time. We've come a long way, but still it wasn't zero. We would like it to be zero, of course. And about 3% of these patients were discharged to an institution other than home. So they went, for example, to a skilled rehabilitation facility because they were not ready to go home. They still had problems. Complications were not uncommon. 26% of patients had some complications, and I'll share with you some of this information. So this is what they did, is they looked at the number of pituitary operations, and they put them into 4 groups, depending, that were really analyzed according to the volume of pituitary surgery at the institution. So what you can see, each horizontal bar represents a quarter of pituitary operations. And you can see that, and these are really arranged according to the hospital volume, the hospital caseload, how many patients had pituitary surgery at that institution in that given year. So it's obvious that about 408 hospitals, actually, they had only 1 to 4 pituitary operations per year, very few pituitary operations, and so on. You had 140 hospitals where they had 5 to 9 operations per year, and only 20 hospitals had 25 or more pituitary operations per year. And what is really seen here is, even without delving deep into statistics, that the likelihood of going home, it really improves. So this is the discharge to any institution other than home. So going, for example, to a rehabilitation facility. So if you were at the hospital where more surgery was done, you were actually much less likely to go to rehab facility, so more likely to go home. So the trend is clear, I think, and it becomes even equally clear when you look at the same data in relation to surgical expertise. So again, you have each of these bars represents a quarter of pituitary operations during the study period, but in this case, they're stratified by the surgical experience. So interestingly, 534 surgeons did only 1 pituitary operation per year. I mean, this is really stunning, I think. On the other end, 36 surgeons here did 8 or more pituitary operations per year. And again, the trend, I think it's clear that if you are operated by a surgeon who does more operations, you're much less likely to end up at a rehab facility and more likely to go home. Of course, there are other factors that can lead to can affect the patient's disposition. For example, age or severity of illness, comorbidities. So they try to account for that, to adjust for that statistically. I won't go into details. But even after adjusting for other factors that could influence these observations, they came up with these findings. So what about the risk of death? And that's the risk of death around the time of the surgery, short term. Again, similar trends when you look at the mortality risk around the time of the surgery in relation to the hospital volume, higher in hospitals where the very little surgery is done, 1 to 4 pituitary operations per year, lowest when done at a place where more pituitary surgery is done. And then looking at the surgical expertise, again, mortality risk, surgical expertise, the surgeons that had the highest experience here, 8 or more cases per year, which by modern standards is not even considered that high, but nonetheless, you can see the trend is unmistakable. You know, these surgeons had close to 0 mortality rate as opposed to the surgeons that did 1 operation per year. So I think this is quite clear. What about complications? These were not uncommon, and some of them potentially serious: stroke, bleeding, intracranial hemorrhage, problems with the sodium, diabetes insipidus, low hypopituitarism, spinal fluid leaking through the nose, problems with the nerves that control the eyes, leading to double vision, blood clot, DVT. Those were not unusual. What's the likelihood of developing such complications in relation to the expertise of the surgeon and the hospital also case volume? So looking at the risk, at the complication rate, again, a very similar trend. The patients who were operated at higher volume hospitals did much better compared to those who were operated at low volume hospitals. And then similarly, for the surgeons that did more pituitary surgery did much better, fewer complications compared to surgeons that did less pituitary surgery. So I think if you're a patient, you would rather be operated by a surgeon who does more pituitary surgery. What about length of stay? During the study period, it went down, and this is the trend that's unmistakable across the country for a variety of reasons. But still, on the average, it was 4 days during the study period. It was shorter in hospitals with a larger volume of pituitary surgery and also surgeons who did more pituitary surgery. Charges are much higher, I'm afraid, today, but nonetheless, they went up, or even during the course of those 4 years. But they did tend to be lower in institutions where they did more pituitary surgery. So they tend to be more efficient, I think, and help the patient get through with fewer complications and fewer hospital charges. So based on these types of evidence, a task force of experts from the Pituitary Society got together and they drafted a set of proposed criteria to define the mission and characteristics of pituitary centers of excellence. And these were debated by the membership, approved by the board of directors, and a document was endorsed by the membership and was published. And I'll just give you a few highlights. So according to the Pituitary Society document, again, the mission of the Centers of Excellence is to provide the best possible pituitary care in a multidisciplinary fashion, and then work across specialties to provide best possible care, train fellows and residents, be active in public outreach, and patient education, advanced pituitary science, and of course, be accountable and audited periodically. So some highlights, again, neurosurgeons, they ought to have training in neurosurgery and also additional training in pituitary surgery and practice at a high volume institution. It was suggested that perhaps 50 pituitary surgeries or more per year would be a good benchmark for a pituitary surgeon to have adequate experience, although that's debatable. And they have to be active in pituitary science as well. Similarly, endocrinologists who practice in such a center ought to have the appropriate training and postgraduate training at a center with pituitary expertise, and also be active in research and advanced pituitary science as well. So this is how it's supposed to work. So the Pituitary Center is led by a neurosurgeon and endocrinologist who work together with specialists from other disciplines: radiology, pathology, radiation oncology, ophthalmology, I would add neuro-oncology, and as well as nursing staff. That is very, very, very important, to help advance the mission of the center. So the workflow of the Pituitary Center, there are going to be external units. This could be smaller hospitals or endocrinologists who will be referring the patient to the center, where they will get holistic care for their pituitary condition, including Cushing's. And then, of course, the patient will be returned back to their local doctors for ongoing care. And at the same time, the center is going to be accountable to administrators and audited periodically. So this is the concept. So in summary, what I tried to show you was that we have some information suggesting that clinical outcomes are improved when patients undergo pituitary surgery by more experienced neurosurgeons operating at higher volume centers. And the Pituitary Society has proposed some criteria for the Pituitary Tumor Centers of Excellence. However, currently there's no formal accreditation process. So the establishment of accredited and audited pituitary centers has the potential to further improve the outcomes for patients with pituitary tumors, including Cushing's disease. So I'd like to thank you for your attention, and Dr. Archimescu will take over.
Thank you. It is very nice to be here. Thank you so much, Leslie, for the invitation. Those of us who are here in Atlanta would like to tell you that the summer usually doesn't linger that long, but we're happy to offer you another summer day. Maybe the weekend will be the same. Because me and Leslie have a relationship for a few years, she gave me probably one of the hardest talks, right? Because I have to tell you what to do when the closest pituitary center is far away. And I'm going to try to show this looking through my own lens, as someone who sees patients who many times live far away. But before doing that, I think that it's important to figure out how to locate a pituitary center. And many of you have been through this process again, but you can, because you're here, because you're part of the CSRF, you can advise others how to start, because sometimes it's very difficult to find a place to start. So the local endocrinologist who might suspect the diagnosis is a good resource. Also, sometimes patients go directly to a local neurosurgeon with a tumor, so that's a good place to start, because hopefully they would acknowledge the fact that they only do once in a while pituitary surgeries, and there are other colleagues that they know of who are experienced in this field. Patient support organizations are a great place to go and look to see where the pituitary centers might be. There's always a Google search. I think if you do it well, it's pretty good. And once the Google search yields some results, you can go on the website of that center and see what they have to offer and whether that matches at all to where the patient is in their Cushing journey. If the patient is at the beginning of their journey and haven't yet had surgery, I would say the most important thing is to find that experienced neurosurgeon. It's really by far the most important factor in a good outcome. If the patient already had surgery, but the disease recurred, or there are issues with maybe not remission, that's another reason to look for an expert neurosurgeon who might have another insight. I couldn't find too many papers after Dr. Tritos did his search, but I found one. It's not specifically referring to Cushing as the others were. It's a review from 2018. They looked at the experience with transsphenoidal surgery and importance to outcomes. And I only took the small part that pertained to Cushing's disease. So they did look at 59 publications in more than 5,000 patients, and remission rates greater than 85% only were reported for single surgeon series. So that goes in line with Dr. Tritos' talk. So it's very important to have a dedicated and expert neurosurgeon. And then they also found a correlation between early remission, meaning how low those cortisol levels drop, and the number of operations that neurosurgeon did for Cushing's disease. So I think, how many are enough is hard to tell, but I think an honest conversation with the neurosurgeon is needed to see whether they've done enough or not. What would be other reasons to visit a pituitary tumor center of excellence? Maybe surgery is something that already an expert neurosurgeon said that it's not something that is needed. Well, there's some of us here, Dr. Neiman, Dr. Gear, and Dr. Stratakis, and others, dedicated endocrinologists. We really know pituitary and adrenal very well because we see this all every day in and out. So we evaluate a large number of patients with rare diseases, and Cushing's is one of them. There are others that are rare. And we offer second opinions for challenging cases. And we have experience with medications that are otherwise quite rarely used by general endocrinologists. Our colleagues are wonderful, but their pathologies mainly consist from diabetes, thyroid, osteoporosis. So once in a while, if a dedicated person who sees just rare diseases might be important to consult. What other reason would be? Well, multidisciplinary care. These are tertiary and quaternary referral centers. So these are places where if you need an IPSS or inferior petrosal sampling testing or another dynamic test that might not be offered locally, that's the place to look for this. That's the place where they'll have the latest proton centers, for example, the most modern ways of delivering care. That's what you expect from a tertiary referral center. And then the research activities. I mean, you would like these professionals to capture and track their data, to look at their outcomes, to present at meetings, to be able to publish their results. Maybe the patient is somewhere in their journey where things are really tough, and they're looking at clinical trials, and they're looking at medications that are seeking approval, but might give hope to one who's tried everything else that was out there. So that's the time to look for PTCOE. Many of us do our own investigator-initiated research. Maybe that's something that you could look into, and publications, because these publications are peer-reviewed, so there's some quality to them. And finally, this is the place where educational activities take place. Whenever you have to teach someone, I guess you have to know that part yourself first. So the way I would like to approach this is with the patient who lives far away. I'm not going to put a mileage to it, but I don't know, 150, 200 miles to me, that's pretty far in the center. And then they've located this pituitary center, which is usually in a sizable city. And then they have their clinic, their local clinic, where hopefully there is an internist, an endocrinologist, several specialties. This patient needs labs once in a while, and they also need to have an MRI of their pituitary gland once in a while if we're talking about Cushing's disease. So how do we make it all work? Well, I think the local endocrinologists have an extraordinarily important role because they communicate with the specialists at the center. They are able to see patients in between the visits at the center, and this way the visits are more spaced out. They're able to manage those other problems that the Cushing patient has, blood pressure medication, blood glucose management, and so many other issues that might come up, even on an urgent basis. They might see them there in the office rather than having a long trip ahead. And most importantly, they remain involved in patients' care. So, the pituitary centers are not seeking to take over these patients. No, we're just here as a resource, and we would like to just deliver those services that aren't available locally, or advice when that's needed. So, if I was to put a picture on all the slides, the most important one I would put here would be a cell phone. If you look at my cell phone addresses, all my colleagues from Georgia and some states around, we have our cell phone. And it's the same with with Dr. Oishiku, with my neurosurgery colleague. He has the cell phones of all endocrinologists in the state as well. That's the kind of relationship that needs to exist for a good collaboration. So the local laboratory. Now, one good thing is the salivary cortisol kits are not a problem anymore, right? We can give those to patients when they leave our clinic. They can take them, they can use them at home, and then they mail them back, no problem. Now, with anything else, from blood draw of ACTH levels that is measured in picograms per milliliter, and it sits too long, is not put on ice, that number might not be relevant, to the typical 24-hour urine collection that I think probably almost everyone who's a patient in this room has experienced it many times. Things can go wrong. So some experience of the local laboratory in handling hormone measurements is important. And when one goes there, there are several things that need to be asked. First of all, what's the turnaround time for results? Maybe I need those results by the visit, and I'm going to travel 200 miles and stay at the hotel, so maybe those results are needed, and am I going to get them in time? Will the patient be able to access those results directly? There are some laboratories that offer their portal, and then the centers have their own portal, so that's electronic access, so that's good. Otherwise, we rely on the faxes, and who's receiving that fax, right? I mean, is it going to be the local physician who has privileges there? Is it going to be the physician at the center? So the phone number of the laboratory is essential, because then we can call them and get those results over. How about the imaging center? So if imaging is done locally, after the scan was completed, patients can request their images to be loaded on their disk, and that disk can be mailed to the center, and then the specialist can review them with their own eyes. In addition, let's say there is an issue of relocation or a third opinion or a fourth opinion, a patient has their disk with them, then it's perfect because it can be shared with others. Now, one word of caution. Protocols used for pituitary MRI are not standardized across different imaging centers. And patients with Cushing's disease many times have small tumors, and 20% of them have tumors that cannot be seen on the MRI. And post-operatively, that's tricky too. Is that a small tumor residual? Is it just post-op change, or is something growing there? So visualization of small lesions requires modern technology, and modern technology is not the same everywhere. So it's good to check in advance, both with the pituitary center team who's ordering that scan and with the insurance company, because obviously their demands could be of different kinds. If surgery is done elsewhere, protocols differ from center to center, especially for the first 6 to 8 weeks post-operatively. So those need to be followed based on what that center has in mind, because that's their way of doing things. And it's the way that worked for them. So it's not good to change the team in the middle of the game. Now, if surgery happened a while ago, and now the patient is seeking opinion from a new center, then medical records are essential. And we truly want everything from operative reports to anatomic pathology reports to laboratory results, imaging reports, anything that you can get. And patients should have their own file and only share things like after copy, okay? Don't take this away from me, because maybe the next person will need it. One word about neuropathology standards. These are a moving target. So if surgery was done 10 years ago elsewhere, we might request a slide or the specimen to rerun it with the modern requirements in mind, because we want to give an advice in 2019 based on criteria that are actual and not something that was there before. So don't be surprised if that happens. So before running to the car, because we're always late, and leaving our house, and let's make it on time to the center, don't. Just stop and take a deep breath in and think, did I take my medical file? Did I take my newest laboratory results? Or maybe the center already confirmed that they had them. They were done last week. Do I have them? Do I not? Medication list. If it's not there, if it's not updated, then just take all the meds. Just take them all, put them in a bag, and take them with you. The disc, right, where the last imaging study was done, and most importantly, a note for like the questions that you want addressed. As you've heard here before, there are different symptoms, there are different manifestations. Those may or may not be related to the actual discussion that will happen, but we will never know until we hear them, until we address them. As Dr. Neiman was saying before, I often walk into a room having everything that I need. I'm all smiling, your levels are great, your MRI is great, and then I see someone who's really not feeling that great. So, and the discussion can quickly stir into a different direction of things that are important to us because we want to keep our patients safe. And then those things that are important to the patient, they may just say, I wish I told her, when I was there. So those 4 things, I would say it's a good checklist. And I have no conclusions because I think this is an open a space that has to be open to discussion, not only from the 3 of us, but from you, the patients, from Dr. Oishiku, who is our neurosurgeon, who has a very important role in our team, and from Lisa Ward, our physician assistant. We don't have our nurse because he's out of town, but these are things that all our team is experiencing in different flavors and in different from different angles, and I think it's an important discussion. But my opinion, my personal opinion, is that Cushing's syndrome is the toughest disease to diagnose in the world of endocrinologists, and so having an opinion from someone who sees this several times a day kind of makes sense. The framework for Pituitary Center of Excellence, as Dr. Tritos was saying, it's not there. I mean, it's still to be established. There's just those of us who deal with these patients, who know how much they suffer and how long they've waited to see someone who made the diagnosis or got to the treatment, to the correct treatment. And I think that the voice of patient support and advocacy groups is extraordinarily important. So if you make your voice heard to the legislators, to the insurance companies, things might be different next time when we meet. Okay, thank you. Who has questions?
I think you left out a real big piece, and that's the insurance. Workers say they've had a fight with insurance for months and months and months.
Yes, now it's here. I mean, I was thinking there or not, but I did. You see, it's like that. I know. That's what I'm saying. That's where the patient's voice need to be heard, to go over all those hurdles that are put in front of all of us when we become patients.
What about the people that are not quite, up to fight with insurance? They can
I totally agree with you. I think that's a issue, and that's why I think that if the framework of the Centers of Excellence moves forward, and indeed we have, audited and accredited Centers of Excellence, then the insurance will have no way, they will have no other, way but approving, the patient's visit to the doctor of your choice. Until then, of course, the question is what to do. And I think that's really a challenging issue for many patients, and I've heard many stories. So one thing that could be done is, of course, for your own home doctor to write a letter to the insurance and say that, why this is so important. So advocate on your behalf. It may or may not work. In some cases, it may work, but I understand it's a difficult issue. For some other patients, I think the problem can be locating an experienced surgeon, an experienced physician. And as Dr. Erkimascu said, using the internet can be helpful. Some professional societies do have directories. The CSRF actually has a physician directory as well. Pituitary Society has one, and other professional societies, so that can be helpful. But I understand that this is a major problem.
Yeah, there is one colleague of ours who's an, that's what you're going to say? Lisa, why don't you say it?
She's actually retired from endocrinology, which is tragic, but she believed so profoundly in the benefit of a pituitary center, the need for the skilled and experienced neurosurgeon who has done more than 3,000 cases of transfemoral surgery in his career and sees this all the time, that she actually created a boilerplate. And this is actually Kaiser, so it's very insular and difficult to navigate within. Created a boilerplate where she, bullet by bullet point, stated why it was necessary for her patients to be referred. And she used it time and again, and we got those patients with very little challenge. And maybe that's an opportunity for us to create something that can be downloadable and utilized.
These papers that were presented, like when any physician for a medication that is not on the preferred list, what we go is to the actual literature. That's how we do our letters. We explain that giving bromocriptine for acromegaly or Cushing, the way the insurance company suggests is really not the right way to go. And we go to the literature and we put the exact numbers and why a medicine that might be very expensive for the insurance company, has results or has been approved by FDA and so forth. So we just have to go to the actual data, and generally the insurance company is responsive to hard numbers and words that have to, that state that the safety of the patient is in. Nelson, do you want to add something?
So I think I just want to add some comments. We published a paper on this particular issue of pituitary tumor centers of excellence in 2012. Dr. Ed Laws was on it, myself, Larry Katz-Nelson, and Dan Kelly. And our thought process at that time was to set this ball in motion. It's by no means a novel concept. There are centers of excellence in a host of medical conditions, bariatrics, trauma, heart disease, and so on. And it does require a little work to put it together, but it does need to be done. There's a perception out there that pituitary tumors are easy to remove. You just go in there and just suck them out or something. And this is absolutely untrue. Sometimes they can be removed easily, but pituitary tumors are not easy to remove, and they should not be couched in those types of thought processes and terms. That's what gets people into trouble. I think one of the things that we have to work on, we've been working on this for a while, is the issue of independent audits. In other words, to have a third party, somebody who is, or some institution preferably, who's independent and can look at things, and so that you get in between the hospitals and the insurance companies and the physician practices, because there's always the issue of whether this is being done in a self-serving thing. So if an independent auditor, like a good housekeeping seal, is brought into play, then chances are that things will be more likely to be attended to by the insurance companies and so forth. I think the other thing I would like to say is that all the data that you see in terms of the hospitals and the surgeons and so forth, you should remember that outcomes and complications are surgeon specific. It's not enough for a surgeon to say, oh, the chances of surgical remission in Cushing's disease are 91% in the literature. Okay, yeah, there is data, and there are data to show that in some cases, but That's not that surgeon's data. That's somebody else's data that published it. So I would urge you, when you look at that, you ask for surgeon-specific data and hospital-specific data, because it's not enough to just pull something out of the literature. You may also be doing 50 cases a year, but your initial remission rates may be completely different from the other surgeon 2 doors down the line. The internet is a great resource, for sure, but it also needs to come with a warning label. Because if you don't know how to interpret what you see on the internet, it could be a problem. And one of the things I always like to tell my residents and fellows is, there's a quote. It says, "Good judgment comes from experience, yeah, and experience comes from bad judgment." And so you have to. It takes a while to learn a lesson, and there's this thing called the 10,000-hour rule, and I think that's true. But then you have to ask yourself, okay, if I've not done 1, how am I going to do 2? And if I haven't done 2, I'm not going to get to 4. So how does it happen that you get to be a surgeon that's done 500 or 600 or 1,000 or 4,000 or 8,000 lifetime, whatever it is, lifetime cases? And the answer to that is, it's like the journey of 1,000 miles begins with 1 step. And so we have to teach the next generation. They have to be by our side. It's kind of like an apprenticeship. And you've got to have a surgeon who has a fallback. In other words, it can't just be them. What if something goes awry, and who's the plan B for that surgeon or that hospital? That's the kind of questions that I think are very important to ask. And even for the best of the best, there's something called risk stratification in surgery. What that means is that each patient is unique. Their disease is unique. Their risk factors are unique. The weather on that day that they have their surgery is unique. And so what happens to one patient may not be what happens to the 2nd, 4th, and 5th patient. And so there are some cases that are very difficult, as you saw, a tumor that's intracellular versus one that's extracellular. That's a different kind of tumor, and the results would be different in terms of expectations and so on. So just some thoughts on this. It's a very, very complex issue, but it's not the first time we're going to deal with this in medicine. And so I'm very, very much in favor of this concept. I think it's the way to go, and I think CSRF and other advocacy groups like that, Pituitary Society, Endocrine Society, need to take the leadership on this, because it's extraordinarily important for patients to get the best outcomes and the best results the first time around, and not the nth time around, if they can help it. Thanks.
I keep that's because I'm told that you need to have us talk into a microphone to get everything done. I needed a pituitary center for the first 11 years that I was not diagnosed. I would have loved to have known this knowledge at that day and time. So maybe I wouldn't have had the disease another 7 or 8 years longer. But I still find by the way, my pituitary center is Johns Hopkins Hospital in Baltimore, so I know I'm in great hands today after an unsuccessful surgery the first time. But as a patient who is in recovery now, 18 or 19 months in remission, I didn't know I could experience so many more illness from the recovery of Cushing. So what Cushing's caused before I did finally reach remission in 2018. Examples I can give you is I must see a nephrologist. I've had 2 kidney failures, and obviously I had hypertension at excessively high levels for an amount of time. I had to see a physiologist, and I go to a PT 2 days a week because of the muscle atrophy issues. And honestly, I had numerous strokes, ruptured aneurysm, so there's a lot of things that went wrong with this Cushing patient. An orthopedic surgeon is who I also have to see from herniated disc, who he's been competent in completing 2 cervical surgeries and a lower lumbar surgery, and I have a 4th surgery that is underway. Let's see what else. A neurologist is working with me because those herniated discs were pinching the nerves, and so I have 3 nerves that are very compromised, and this is all affecting my lower limbs, for sure. For all the time I've had Cushing's, I needed a mental therapist like Georgie Eden sitting right here next to me. And it would be nice for pituitary surgery, or pituitary centers of excellence, to be able to help the patient through this maze. Ophthalmology, optometrists, we know we have bad eyes after Cushing. My PCP, what a wonderful lady. She admitted she did not have the Cushing's expertise and relied on my doctors that have gained the expertise with me being their patient over this last decade and a half. But she recently completed a best doctor's report. I'm pretty sure she paid about $45,000 for someone to do a detailed history on my health. And it was a pretty extensive report. But their recommendation back to my PCP was a whole step short of the latest surgery I had just in June. They were recommending something, but they missed the real surgery that was clear up in the top of my neck. Oral and dental, you already heard me crying about the pain. How in the world does a cushy, and we can't experience these kind of ailments? And I know I'm not naming all of them because you all tell me about illnesses you have that I haven't experienced. How do we ever find that Cushing's Center of Excellence where we can help that patient predict? These are all the things that can happen to you. I am still dumbfounded my neurologist and my orthopedic surgeon on nerve damage because they cannot see the pressurization. So they're going to consult with a neuroradiologist. So I went to Google and tried to make sure that that is the doctor that's going to focus on the central nervous system. They're still dumbfounded because they just don't quite fully understand how Cushing's has potentially impacted these other parts of the body that are not normally the things that we're going to focus on in the pituitary center. But I believe all of you know that we encounter this as patients trying to figure out what the heck is wrong with me. I wondered.
Like, okay, so in 50 years, if I'm still around, like what will we look back on and think, oh God, we didn't realize that, but now I think about dental all the time because I know I brush my teeth more than this does not match up to my, the way I treat my mouth, but I'm really curious about that too. I don't know if you guys can just quickly come up with a list of symptoms that are actually related to Cushing's that we all think are, because after you're sick, you don't know what's, I have a big problem with that. I don't know what's Cushing's related and what's just I'm getting older or I'm a woman or whatever. I don't know. I feel your pain. I guess that's what I'm saying is like, I know what you're talking about. Marie?
I just wanted to, first of all, thank you guys. I started a small fund a few years ago, and to date, we've trained 507 medical residents, students, and doctors on early diagnosis. The one thing that it never ceases to amaze me, we're not really working specifically with the endocrine, although the endocrine team is the one helping to present. We're really focused on OBGYN, orthopedics, ER, family medicine. So that would be the one thing that I found, because I'm working with two pituitary centers, and specifically, and even then when we're having these conversations with the different specialties, everybody goes back to, yeah, Cushing's, I remember learning about that my second year in the first quarter, and you're really rare, and we're like, got it. So, and there's never a referral automatically to endocrinologists. So one of my recommendations would be through these 507 individuals is pituitary centers really, in order to really have that impact on patients, it needs to come from the bottom up. And I know all of us specifically, I saw 7 specialists at my first hospital, not one was an endocrine. So that would be my recommendation as you're talking about this in terms of the pituitary centers, is really starting to put into that portfolio is an education within the different specialties. And it's not even so much specialties anymore, family medicine and ER. And I focus very specifically on nurse practitioners as well. So, and then residents, because I figure if we can get them in that first year, and also first year students, because they don't touch any humans, and
I always feed people. And it's not pizza and salad, it's like really good food so that they come. So I think that would be, you know, an offer that I would make to you guys in terms of, as you're teaching about this, look at what, you know, your own colleagues are generally missing, so.
Yeah, thank you so much. I think that's an excellent. Because, as you pointed out, the patient is not going to present to the Pituitary Centers of Excellence to begin with. They're going to present to their gynecologist or their PCP, their family practitioner. So it's very, very important to, as part of the mission of the Pituitary Center, to reach out and you know, help advance the education, well, not only community outreach, but also advance the education of the physicians and other healthcare professionals, and make them aware, raise awareness of the problem, because that's a relatively rare condition, so I couldn't agree more.
Absolutely. This is one of our missions. I mean, a center must have 3 missions: the clinical, the research, and the teaching. There cannot be a center if you don't encounter all 3 of them. And to the lady who mentioned all the various systems that can be effective, I mean, it's just so difficult to say what's directly related to it and what's not, especially years afterwards when cortisol levels normalized. We do not have a marker that is available for us to check of cortisol effect at the tissue level. That would be something that would answer some of those questions. Until then, what I tell my patients is, what I can do to help, I'll do it fully. But when I cannot treat like someone's cervical spondylosis, so I'll send you to the best spine surgeon that is out there. So every time there is something that happens, don't hesitate to take advice from specialists in those systems that show the problems, because there is only as much, you know, we don't have expertise in all those fields, and working together, multidisciplinary approach is the key to health.
I was just going to say, you know, when I heard the discussions about, gee, why, you know, can't we have a center for this? We have burn centers. We have different levels of trauma centers. You know, we have hospitals that have all kinds of centers, and I would think that an area this large, a center would be one that would be placed with a large population. Because it's a rare disease, I would imagine you'd want to be in that type of situation. So I don't know what the difficulty is. Is it because we're not going to have patient numbers to approve something like this, but looking at being in a center where it's a level 1 trauma center, it's a burn unit for the state or whatever, would hopefully make it a little bit easier. I don't know if you're just looking at one particular area to stay in, or would moving to a complex maybe allow you to see more people.
Probably have time for one, maybe 2. One more question. Does anybody have one more single question? It's you.
So that's an excellent question. Thank you for bringing it up. Of course, I'll let you also give your own, Dr. Chimescu, she'll give her own answer. But I have seen some patients who actually had a flare of the autoimmune conditions after they recovered from Cushing's. And we think that it's because cortisol at high levels is immunosuppressive, and Dr. Neiman actually mentioned that. She told you about the importance of getting vaccinated. So when you lower the cortisol, that immunosuppression, relative immunosuppression is lifted, and that's a situation when autoimmune conditions can actually flare. We've seen that with rheumatoid arthritis, sarcoid, and other conditions, so I'm wondering if this is something that you might be experiencing.
I totally agree. I've seen Crohn's flaring up, and there are all sorts of pain issues, because we all have to be very mindful. I mean, when the cortisol levels are so high, it's beyond how many anti-inflammatory can one take in one day. It's much higher. It's like taking prednisone, therapeutic doses. So pain, that's why pain is something that comes up after surgery, because the pain threshold is affected by the lack of cortisol, especially that it drops. It's the delta, really. It's how much it drops that leads to this, and that's what makes this recovery so difficult.
Which is something that I never thought of or something, but I feel like everything.
No more questions.
So it's just a point, and I'd like to get the opinion of our expert neurosurgeon here. So at the NIH, the person who was the neurosurgeon when I first trained there was Dr. Ed Oldfield, who really, in some ways, spent a lot of his career taking care of Cushing's patients. And when Ed first started, his success rate was not as good. It really mirrors what you pointed out, but his success rate got to be extremely excellent. And he attributed it to a technique that he, I think, pioneered himself. I thought was that as the tumor grows, it pushes the normal pituitary and it creates a squished up area, like you would take a sponge and squish it. And that allowed you to allowed the surgeon to both by touch and by vision to create a plane where they can basically go all around the tumor and take out the tumor in one piece. And he felt that that prevented people from leaving pieces behind if you did it piecemeal, taking little bits out as a bit. And so he's published a remission rate and then trained, as you mentioned, 2 people since who have the same remission rates of about 95% for microadenomas, which is a really good number compared to some of the things you see in the literature. And so that might be one additional thing to add in to not just the number of surgeries or the types of surgeries or big tumors or little tumors. So I was wondering if you would like to comment on that.
Great point, Lynette. Before I answer the question, if anybody did not know Dr. Ed Oldfield, he was a consummate gentleman and a first-class surgeon, and it's a shame that he's passed on. He was a great friend and a great mentor. So Ed Oldfield sleeps well, I'm sure, and we all owe him a lot of thanks. So the point that Lynette raised was this point about technique. And so before I talk about that, is that practice does not make perfect. Practice makes permanent, and perfect practice makes perfect, excellent outcomes. And so that's very important. So it's not enough to repeat something over and over again, because if you repeat the wrong thing over and over and over again, you get very, very good at doing the wrong thing over and over again. And so the technique is very important. You've got to be taught the right way and then replicate it with the number of reps and get better and better and better. And the description of the microadenoma, Lynette, was actually by a fellow by the name of Jules Hardy, which I'm sure Jules rings a bell. And Jules Hardy, I think it was in the 60s, described the concept of what's called a selective microadenomectomy, which means that you remove the microadenoma, only the microadenoma, and all of the microadenoma. And he showed excellent histopathological specimens, whole glands, with the microadenoma, with the reticulin capsule. It's actually a pseudocapsule because it's not of the tumor. The capsule is not of the tumor, it's of the surrounding tissue. And so Jules Hardy described this microadenomectomy, and he coined the term microadenomectomy. So we owe that concept really to Jules. And Ed then perfected the technique over and over again, long after Jules Hardy had passed on. And he has these excellent videos and so forth which describe the technique in painful detail. And he did the technique in painful detail. And, you know, there wasn't a little drop of blood to occlude the vision, and wonderful, absolute techniques. And that is the way to do them, not to, quote, suck them out, as you may have heard. And when you do that, when you preserve the pseudocapsule, which is the surgical capsule, and that allows you to remove the microadenoma, all of the microadenoma, and just the microadenoma. Now, it is also true that there's the concept of invasion. So adenomas, like many other tumors, can make enzymes that break up cellular boundaries, tissue boundaries. They're called proteases and metalloproteases. They break up the border. It's like somebody crossed the fence into your neighbor's yard and no longer got bound by the pseudocapsule or by the reticulin capsule, and they break away into the cavernous sinus and they enter into that area, or microscopically enter into the coverings around the gland called the dura. And when that happens, then it is not possible, because one cell is 7 microns. So with the naked eye or with the microscope or an endoscope, you can't see that. And so you can get microscopic invasion, and you can get even macroscopic gross invasion as a result of the tumor breaking the normal rules of the boundaries of the tumor. And it gets into the cavernous sinus and the dura or something, or both. And in those cases, the surgeon has been confounded by the biology of the tumor, because the tumor has now no longer retained that envelope, as it were. And it's those kinds of cases that lead to incomplete resections, that lead to recurrences, and so forth, even in the best of hands, because, again, you're at the mercy of the morphology and the biology of the tumor. Yeah. So hopefully that helps. A long answer, Lynette, but hopefully. Yeah.
Thanks for sharing. So we are pretty much done for today. I don't know if there was any success in trying to do like a sign up for the restaurants at Emery Point, but good luck with